Here's a list of objectives. Be sure to review them. We will be discussing them now and then also in lecture on our next lecture day. This is good to review because these are what you should be expected to be familiar with for the exam. Starting off, we have the basic review of the rhythm of signal that follows through the cardiac impulse, starting with the SA node. And as it moves from the SA node, it transfers down to the AV node. From there, it goes through the bundle of His, out through to down into the ventricles and the Purkinje fibers. Just remember some defining items is depolarization, which is the stimulation and the contraction of the heart, and repolarization is the relaxation of the heart, and systole and diastole in their formal definitions. Here is another representation of the signal as it moves through the heart. Remember, your SA node is also considered the pacemaker of the heart. That's where your signal generally should be originating all the time. It fires spontaneously 60 to 100 times per minute. And this is kind of just a representation of what happens on the cellular level. As the signal travels through the heart, the cells stimulates, causing depolarization, resulting in contraction, and then as the cell relaxes, it returns to its original state, and that's deep repolarization. Keep in mind, sodium and potassium are the two primary electrodes that provide charges throughout the cardiac cell. Calcium is also involved in this. So while resting in the cell, potassium is mostly inside the cell and sodium is mostly outside the cell. We just talked about that on our fluent electrolyte lecture, so this should be coming back to you. So just defining ECG is a graphic tracing of an electrical impulses produced in the heart. The waveforms in the ECG represent electrical activity and charged ions across membranes of myocardial cells. And like I said, this is represents depolarization and repolarization. So leads are the imaginary lines between two ECG electrodes. The electrical activity of the lead is measured across and is recorded as part of the ECG. Just some common things. A 12-lead ECG records 12 of these leads or imaginary lines and produces 12 separate graphs on paper. So the 12-lead ECG is the electrical activity primarily in the left ventricle. Just keep in mind, it throws some people off at first. If you haven't placed ECGs before, there are only 10 physical electrodes you place on the patient. So, and then most commonly on most units, you're going to be looking at 2 to 5 lead placements. And those are usually on the limbs and the chest. Here's a quick representation. Just kind of understand. So a lead is considered a view. So here, when you're going through like lead 1, lead 2, and lead 3, it's kind of the direction you're looking at the heart through the signals. So as the signal moves through, and it's important to look at these different rhythms here, what your heart rate looks like through the different rhythms. You'll notice small variations on how, if you're looking through it, how some of the, like this the QRS complex is a lot more shorter than this lead 2, but it's not as short as lead 3. And so just remembering that, so it's important to know what lead you're on when you're trying to help figure out what rhythm you're looking at. So the graph can show and detect a heart's rate and rhythm, the enlargement of the heart, decreased blood flow, presence of current or past heart attacks, and it's a primary clinical tool used to measure electrical and mechanical performance of the heart. When you're placing ECGs on the patient, they need to have a good connection to the actual patient. So if necessary, you may have to clip excessive hair off the chest wall. Make sure to rub the skin with a dry gauze and apply the electrode pad. So it is important to have accurate lead placement and good skin preparation, or it will give possible false readings and false rhythms. Something to think about though, while you're cleaning the skin with alcohol, does remove the oily residue on the skin, but it can also increase the skin's electrical impedance and hinders detection of cardiac electrical signal. So just keeping that in mind when you are scrubbing, that you want to make sure it's dry before you then place it on the like I said, going the importance of placement. We're going to be discussing the placement on the patient. Accurate interpret the ECG depends on correct placement of the leads on it. If incorrectly placed, error in diagnosis can occur. Remember, you're looking at the heart from different angles, so if those leads are not in the right spot, you're going to get obstructed views, or the rhythm's not going to look appropriate, and you could get, and that could cause, either poor diagnosis or poor treatments. To prevent interference from the electrical activity, make sure the limb electrodes are placed in areas that are not bony and do not have significant movement. One or more of the ECG leads can be used to continuously monitor the patient's ECG. Most common you're looking at are leads 2 and V1. So here's just kind of quickly discussing where the placement is of all the leads on the patient. Remember, V1 is in the fourth intercostal space, just right at the sternal edge. Going on to V2 is the fourth intercostal space, septal view of the heart. 3 is midway between V2 and V4, anterior view of the heart. And then V4 is fifth intercostal space. And as you see, in V6 leads through. So basically, as you move through, it moves around the heart, following this pattern. And then your limb electrodes, you got LA, RA, LL, and RL. Those generally are placed either on the arms, at the ankles and the wrists, or you can be placed up in the right and left clavicle and the upper thighs. So the monitor continuously displays the heart rhythm, and ECG paper is attached to the monitor to record the rhythm, and they commonly refer to as a rhythm strip. And this allows measurements of complex intervals and for assessments of dysrhythmias. So now we're going to start discussing how to correctly interpret an ECG. First thing you're going to do is look at the time and the voltage on a paper. So the paper consists of large heavy lines and small light lines or squares. Each large square consists of 25 smaller squares, 5 horizontal and 5 vertical. Okay, and the paper which ECGs are recorded upon is standardly used across all hospitals. I mean, it's hard to say all because there's always, there's always one that does something different. But each small square represents 0.4 seconds, and each large square represents 0.2 seconds. So there's a small square, that's 0.4 seconds. And then this big old section here, or well, actually from here to here, would be considered 0.2 seconds. So 5 times 0.2 would be 1 whole second. So if you think about it, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 15. So I said, so 15 squares equals 3 seconds. So, and they do, each strip usually has little hash marks, and each of those is 3-second increments. That's used for calculating, that's used for helping it calculate rhythms. And then horizontal axis, it records time, and then each millimeter says 0.4 seconds. This means one large square equals 0.2 seconds, and 300 squares equals 1 minute. Vertically, you're looking at amplitude, that's the voltage. So each square is 0.1 millivolts, and each large square is 0.5 millivolts. So just kind of keep in mind, distance, and then the height is your millivolts and how much voltage it is that's being changed. ECG is comprised of waveforms and segments of interviews. You got your P, your QRL, your P wave, your QRS complex, your T wave, and your wave. And then there's several intervals you want to make sure to measure, and those are your PR interval, your ST segment, QT interval, and TP and PP intervals. Here's kind of just a quick another diagram of a rhythm. You got your P wave starting off. Okay, here I come, and then you got to get from the atrium to the ventricles. That's this part right through here, and then your QRS is making the ventricles contract. And ST segment is taking a little break, so that's your, and this is your, and T wave is ready to go again. So this is your depolarization and repolarization of your atrium and ventricles. All right, one complete cardiac cycle is one P, QRS complex, and a T wave. So this is one heart cycle right here. Okay, and different intervals are down below here. just another representation of kind of what's happening to the heart during these rhythms. Your P wave represents atrial depolarization. Your QRS represents ventricular depolarization, and your T wave represents ventricular repolarization. If you're wondering where the atrial repolarization is, it's typically buried inside the ventricular depolarization. That's why you don't see it. All right, and then going through just another representation. Like here's your P wave, your PR interval, your QRS, QT interval. So here's just kind of a representation of all the different measurements that you can do on one rhythm. It would be good to know these different terminologies, what a P wave is, what QRS, T wave, be sure to review all these. And also on page 716 includes the information on the duration. You're definitely going to want to start learning the duration of these primary things, including specifically like the PR interval and so for specifically PR interval, your P wave, your QRS, how long these are, because different widths and different lengths can represent different sorts of represent different rhythms. So looking at your rhythm strip, your positive deflection is the waveform moves towards the top of the paper, and a negative deflection is the ECG moves towards the bottom of the paper. So when you're doing this, interpret the rhythm and assess the clinical status of the patient. Is the patient hemodynamically stable? Assess for hemodynamic instability, like we're talking about chest pain, hypotension, palpitations, dyspnea. Determine if there's a need for intervene. Call the rapid response team, for example. This is a part to determine the cause of a dysrhythmia. Something else you want to look at is assess the patient, not the monitor. A lot of times the monitor will be going off, and you'll run into the room, and it's the patient just tapping on their chest on one of the electrodes. Or if you've been in peds, when I don't know if you guys had your peds clinicals last semester, when the little kids are running around, they have their pulse oxes on, they have their rhythms on, they're bouncing around, moving around. You're not going to get a good rhythm, and you're going to get a whole bunch of alerts on them while they're doing that. So heart rate determination. So now that we kind of have an idea what a PQRS are, what a heart rate is, what a heart sequence is, now we need to look at the paper and figure out what your rate is. Remember what we said, each square box is, it takes 15, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15 boxes to equal 3 seconds. So 30 boxes would be 6 seconds. If your rhythm is regular, there's several ways you can count it. First off is, like you said, you can take the ventricular and atrial heart rate, determine the rhythm by taking 1500 divided by the number of small boxes between the two P waves. So if you were to see like your P wave right here and go to your P wave here and count all of them together and divide that number into 1500, that would give you your rate. Or you can take the amount of larger boxes and divide that number into 300, and that would give you your rate. Both of those are wildly, although accurate, they are also very time consuming. And if you have a patient that's needing interventions, the last thing you want to do is, you can't tell them to, hold up, let me count this real quick while you're waiting, So, but the quickest way to do it would be to count the number of either P to P or R to R, and just basically count the number of QRS intervals inside of a 6-second strip, and that would give you your rhythm. For example, there's 1, 2, 3, 4, 5, 6, 7. There's 7 QRS intervals in this 6-second strip, so your rate would be 7, and there's 6 seconds, so 6 times 10 is a minute. So that would be 70 beats per minute would be a rough estimate. Note that every 3-second marker on paper, like I said, you got a 3-second marker, a 3-second marker right through here. And you count the number of R-to-R intervals and multiply by 10 is another way to do it. I said 1, 2, 3, 4, 5, 6, 7, 8. So 8 times full 10-second thing will give you a heart rate of 80. So that's your estimated beats per minute. Next step is when assessing the cardiac rhythm, use a constant systematic approach. So first thing you always want to do is look at your P wave, and you want to look at, is it upright, is it inverted, is there one for every QRS complex, or is there more than one? Is are there 8 atrial or flutter waves present? We'll discuss that shortly. Calculate the atrial rate, determine if the rhythm is regular or irregular. That's counting the space between the two of them. Is what's the distances. Measure the duration of the PR interval, normal or prolonged. And then next you're going to do is calculate the ventricular rate and rhythm. Measure the number of QRS complexes. Are they normal or are they prolonged? In the ST segment, then you're going to go through measure the QT interval and the T wave. If you've gone through all these, you can identify any rhythm. So that's going to be the ending of this part here. We're discussing this. Looking forward to talking to you again about rhythm interpretation in the next lecture. Thank you.